Ground. Thank you very much, Dr. for joining us here on KTN Prime. The government backed down from mass testing or purported mass testing now to targeted testing. How is this working?
Thank you very much for this opportunity, and thank you for inviting me. You correctly state that we at some point thought about mass testing, but we realized that it made better sense to test for a reason. You know very well that the people who were interested in from the very beginning were those who were infected or those people who were in contact with those who are infected. And we're also interested in people who are in quarantine for obvious reasons. And if you look at the testing we've been conducting right now, the yield is very high. In other words, if we test maybe 100 people, if we are doing mass testing, we might just find a few people that are positive, 1, 2, 3 people that are positive. But when we test those people who we should be testing, when we test for a reason, you do realize that these days we are even getting 15% yield, 20% yield. That is very important for us. This testing costs significant sums of money. I can give you an example. If you go to a private laboratory, you might be charged even 8,000 or 10,000 for a test. Now, as a government is not a profit-making organization. But if you do our math quite quickly, we may find that it costs up to 4,000, 5,000 shillings to test one person. So we are very careful how we use public resources, and therefore testing for a reason makes much more sense. And that's why you are seeing our yield these days is very high.
But when it comes to just helping us tackle the situation on the ground, Mombasa was one of the epicenters for this virus, now recording, low numbers. Would you say the samples that we're getting are representative of the real situation on the ground? How is it helping us fight or curb this virus?
Thank you very much for this question. If we do 6,000 tests in a day, maybe we are going to find just about 15% of those, maybe 700, 600, 800 samples are going to be positive. Is that representative of the normal population? The answer is no. This yield is very high. If we went to the normal population, ordinary Kenyans, and we tested all of them, we would find the percentage positivity is much, much lower. So this is good for us, but you should be careful that when we tell you we have had 10% or more positive, that doesn't mean this is the situation for Kenya. We are testing for a reason. This is the point I'm trying to make.
There's been also concern on the turnaround time for these tests, and when you get your results, some claim in some quarters it takes at least a week. What's the turnaround time for this?
In fact, I had this conversation with my colleagues just about this week, at the end of last week actually, and the turnaround time, the median turnaround time is 36 hours, okay? If you look at HIV viral load testing, which is a major program in the country using the same capacity and the same equipment, the turnaround time at its very best is 5 days, but the expectation is that it should be less than 10 days. So when we were discussing this problem with my colleagues, we realized that people expect for coronavirus to have the results returned to them very quickly. And this is interesting, considering the numbers of tests that we are intending to conduct, and considering the fact that samples actually come in the evening, having been collected during the day, and therefore you've already spent 8 hours or 6 hours from the time you collect the samples. There's a night coming, and we've tried to improve the testing turnaround time by even working through the night and working 24 hours a day. And that has given us about that 6 hours turnaround time. One of the challenges that we have had is not that we didn't test quickly enough, is that we did not transmit the results quickly enough. But you may now have realized that we have already developed software that transmits these results automatically to the clients so that we can bridge that gap in terms of delays, in terms of result releasing. That said, anywhere in this world, in a public service, 36 hours turnaround time is extremely efficient. And perhaps one of the things I would like to think about is how to manage people's expectations. I know people are anxious. Some people want to travel. They want to take a flight now, and they want the results quickly. And the fact of the matter is that we can work together with the public so that we manage the expectation, and also so that they know if they're planning like to travel, they can come to us earlier. we are doing thousands of tests in a day, and we are working both day and night. We can improve this 36 hours, 24 hours, if we take care of equipment downtime, if we take care of reagents so that the reagents are with us all the time, and if we automate as much as possible.
So then,
if we are still manual testing, then of course we expect the timing to be a bit problematic. Yeah.
Fair enough. So then the results we release by the day, how current are they?
The results we release by the day are fairly current in the sense that, like now, I've just come from work right now, and the results we are releasing are results of tests that were, or samples that were collected even as recently as just yesterday. So we don't have samples that are week old. No, we don't do that.
No backlog whatsoever?
Pardon?
No backlog whatsoever? Would you confidently say there's no backlog?
At this moment, there's a bit of a backlog because you remember that manual kits just came in, automated kits. Last week we had some breakdown of some of the equipment, but they were fixed very quickly. But we lost around 2 days because of that downtime. So there's a bit of backlog. But I expect that in the middle of this week, there will be none.
All right. So then this has spread to the counties, and these devolved units are now faced with the responsibility of handling the situation, in the counties. How is, or what is the testing capacity in the counties? Are you, from where you sit, are you seeing any proactiveness from governors to set up these facilities to enable faster and efficient testing?
Thank you very much for this question. If we start by looking at just the infrastructure, you may realize that some of these molecular testing laboratories are in the counties. And I can give you examples. I can give you an example of Wajir, Malindi, Kitale, Busia. These labs are part of the counties, and therefore they are under the control of the county governments. And number two, remember that there are 189 gene expert machines in the counties. And these machines are quite capable of testing for coronavirus. I have seen several governors approaching us, even myself, and asking me, I know I have gene expert machines in my county, but I want more. I want molecular testing. What does it take? What equipment do we need? How much will it cost? I want these answers. And some governors have been very, very proactive in this. If you look at devolution, the Constitution of Kenya 2010, you will see that health services were devolved, that counties were expected to understand the needs of their people and then translate those needs into services and to translate those needs into solutions. And the national government was expected to deal with the referral facilities, or those reference level kind of things, and also to set the policy and the strategy. Luckily for us at this time, the Ministry of Health has been particularly successful at setting the policy and the strategy, especially for coronavirus. They have really done a good job. And these strategies affect the counties, and it's up to the county governments to put their heads together, put resources on the table so they can deliver these services to the people. In my opinion, putting together the infrastructure for them is a straightforward thing. We have this kind of experience.
I'd like us to wrap up in a bit, but quickly. So what is our current testing capacity? Are we on the right track?
Thank you for this. What we did is that previously, for the longest time, we have told you about our equipment capacity. And the last time we told you is that our equipment or infrastructure is capable of taking in 35,000 or more tests. And I can tell you that that capacity has increased since that time. But remember, equipment required to be operated by people. And we also have other things to do. I mean, coronavirus came and didn't find us sitting. It found us dealing with HIV and other problems. And when we were developing the current testing strategy for coronavirus, this is what we said, that we would like to be doing 10,300 tests per day, okay? We are doing about 6,000, 7,000 of those tests. We can actually scale up to around 10,300 because we are looking at what the actual need and what the logical or the rational testing could be. 10,300 tests per day, doing around 70% of that, we can scale up that capacity, but we are testing for a reason. So if we find ourselves exceeding 10,300 tests a day, then we need to ask ourselves, where in the strategy do we need to tweak?
Great.
What are we doing?
That's right. Dr. thank you for joining us here tonight on KTN Prime. Dr. Matilu Mwao is the Deputy Director, Cambry, talking about testing, saying we have capacity. A lot of concerns around this. It's a conversation we'll keep having. Thank you very much for joining us for this conversation. Now, as COVID-19 numbers spike in the country, it is business as usual as the Bukusu Cultural Rite of Passage goes on. The ceremony attracts hundreds of residents who turn up to witness and congratulate